Orbital, yeah. We are live.
Good evening, all. Welcome to iFocus Online, the 362nd episode, 37th in the Oculoplasty module. Today, we have with us a very dynamic Dr. Roshmi Gupta from Bangalore to speak to us on orbital inflammation, specific and non-specific. Dr. Roshmi Gupta finished her fellowship at the prestigious LV Prasad Eye Institute, Hyderabad, and the John Moran Eye Center, Utah, at USA, Plastic Eye Surgery Associate, Texas, USA. She is formerly the consultant and the head of the department of Narayana Netralaya, Bangalore. She has her practice in Bangalore since over 20 years. She was a former faculty at LVPI, Vizag. Her areas of interest include orbit, oculoplasty, and ocular oncology. To her credit, she has indexed articles and book chapters which run over 50 in number, and she is a recipient of Sujata Savitri Roy Award at the AIOS, the Raman Mittal Award at OPAI, Best Video OPAI, the Best Orbit Paper at OPAI, Best Trauma Poster at AIOS, and the Best External Disease Poster AIOS. Over to you, ma'am, for today's lecture.
Thank you, Dr. Prashad, for the very kind introduction. It's a pleasure and a privilege to be here with you today. And I'm going to be talking about orbital inflammation, specific and non-specific. These are my former affiliations, and I have no financial interest in the products mentioned. So we are going to be talking under the headings of the term pseudotumor, the pathology of orbital inflammation, classification by location, classification by specific or non-specific etiology, investigation and management. So as early as 1938, the first case report came in of an inflammatory pseudotumor of the orbit. Typically, the presentation of an orbital inflammation conforms to the classical description of inflammation. There's proptosis, that is swelling, a painful red eye, reduced ocular movement with or without diminished vision. But when we see a patient like that, we ask if the condition is neoplastic or inflammatory. If it is inflammatory, we ask if the condition is infective or non-infective. And then if it is non-infective, we ask if it is specific or non-specific inflammation. That is the sequence of thought we follow. However, although 80% of the patients present with this typical appearance with acute or subacute onset, pain, redness, chemosis, proptosis, and so on, 20% of the patients do present with a mass lesion with minimal pain. Currently, we don't really use the term pseudotumor. We may be using idiopathic orbital inflammation or non-specific orbital inflammatory disease. And in that also, as we know more and more about the disease processes, the pool of non-specific orbital inflammatory disease is shrinking. After 1938, in 1982, Dr. Rootman came up with this classification by location, which has yet been in use. Now, this is something that helps us determine how a certain disease is going to behave. But this is not an indicator of neoplastic versus infectious versus non-infectious. And also, we should remember, even though for simplicity's sake, it's been divided into anterior, diffuse, dacryoadenitis, myositis, and apical, there may well be a combination of sites present in a particular patient. And as we know, about 20% of the patients will have recurrent episodes. And there may be different sites in the recurrent episodes. So if we start off with myositis, the patient typically presents with, of course, proptosis, yes, and pain, but there's double vision and pain on ocular movement. Now, here the thing to remember is that it's not going to correspond to a typical cranial nerve palsy pattern. So if we see something like this, we start thinking on the terms of myositis, thyroid eye disease, which would particularly affect medial and inferior recti, myosisticercosis, or myasthenia. But pay attention to the scan here. You can see that the medial rectus corresponding to the medial part of this right eye is enlarged, as well, and includes the tendon. And the worm's eye view lets us know that the eye is proptosed as well. Typically, there's chemosis and congestion over the muscle insertion. The muscle is thickened and has a ragged outline and involves the tendon as well. It may be unilateral or bilateral. Particularly when multiple muscles are involved, there's a tendency to recur. We will also be on and off talking about, the pitfalls of assuming that it is orbital inflammation. Any disease not responding to therapy should be biopsied. For instance, this patient at first glance looks like it's a myositis, but the history is that he's been on treatment elsewhere for 6 months. And there's an associated bone erosion by the side of the muscle, by the side of the lateral rectus. So here our instincts should come into play and think that, does this need biopsy? Dacryoadenitis is way out the commonest of the locations. There's an enlarged lacrimal gland, there's tenderness, there's localized congestion, and a typically S-shaped eyelid. There will be contrast enhancement on imaging. This may have a chronic cause, but half of these patients are associated with other disorders, which may be sarcoid, which may be GPA, which may be Sjogren. This may even mimic lymphoma. So when we see a dacryoadenitis, we should be having a very high index of suspicion for systemic investigation and biopsy. When you see these two patients, they apparently look exactly the same. And even their scans look almost the same. However, the lady here has an ensoyed, a non-specific orbital inflammation of the lacrimal gland. And the gentleman has a lymphoma. Anterior and diffuse locations may be present for orbital inflammation. Typically, there will be pain, proptosis, and edema, and there will be a diffuse soft tissue shadow. And this is where we differentiate it from the lymphoproliferative lesions. This may be associated with ocular inflammations, including uveitis, scleritis, papillitis. There may be irregular inflammation adjacent to the globe. And in this patient, for instance, the tenon space is accentuated and the T sign is present with a scleritis. Let's look at this patient. There's a typical reddish appearance. However, in his systemic workup, he has a very low WBC count. And there's a typical preseptal lesion, which is molding around the globe. And when we biopsied, it looks like a sheet of lymphoproliferative cells with CD3 positivity, high Ki67 index. And this turned out to be a high-grade T-cell lymphoma. Another example, this was during the phase when there was so much mucormycosis in the pandemic. This gentleman was referred to me as probably a mucormycosis, and he had undergone 2 biopsies from the nasal turbinate, negative for mucor. However, if you look at this, you can see the muscles thicken typically. You can see the enhancing orbital fat bilaterally. And when we know this is a hyperthyroid patient on treatment, and we see CBC is within normal limits, with simply treatment as per thyroid eye disease, the patient recovers. Apical disease is comparatively rare, and apical disease can be exactly at the orbital apex. It can be at the superior orbital fissure in the Tolosa-Hunt syndrome, or a cavernous sinus disease. The functional abnormality is disproportionate to the inflammatory signs. So the optic nerve as well as the other nerves can be involved. There can be pain on movement, diplopia, and early loss of vision. When we speak about specific orbital inflammations, we will be talking more about the common ones because there are quite a list of what specific orbital inflammations may be. We will be talking about the systemic manifestation as well as the ocular manifestation. The commonest possibly the commonest of the specific orbital inflammations is the granulomatous inflammation, the sarcoid or the sarcoidal reaction. It might have multiple manifestations. The commonest, once again, possibly is the involvement of the dacryoadenitis. Let's see, can we have, which involves the lacrimal gland, and this might lead to pain as well as dry eye. It can be an isolated, simply an orbital mass lesion, which mimics a tumor. In this gentleman, you'll see an anterior orbital inflammation. And in this lady, you can see an inflammation which goes around the posterior surface of the globe, and there is a perioptic neuritis, and she presented with blurred vision. Granulomatous inflammation typically should be having granulomatous non-necrotic inflammation. That's very important. Among the possible causes would be, for instance, a ruptured dermoid cyst. We do check for ACE, we check for serum calcium, which would be elevated in a sarcoidosis. However, isolated sarcoidal reaction is also known. It does not necessarily have to be a complete systemic sarcoidosis. When we are looking at this, our pathologist is going to rule out the other possible causes of granulomatous inflammation, such as staining for Zn stain. There's going to be the special stains for fungal infection, as well as we would do a PCR for MTB. A typical sarcoidal inflammation around the eye may additionally have uveitis, chorioretinitis, conjunctival nodules. There may be optic nerve sheath sarcoid, and there may be facial palsy. Facial palsy is one condition which is associated with sarcoid, but not with any of the other inflammatory orbital diseases. The granulomatous inflammation of sarcoidal disease would need a chest imaging. This one here, the chest X-ray is actually showing up the hilar lymphadenopathy, but a better choice is a contrast-enhanced CT scan of the thorax. There may be hilar lymphadenopathy, there may be pulmonary nodule, there may be a collapse of a lobe. There can be multiple granulomas on the skin and other skin lesions, and there can be erythema nodosum, as in the lymph of this. Orbital sarcoid is commoner than previously believed. In fact, quite some years back, people used to say, oh, there's no sarcoid in Indian patients. But that's not true. We definitely do see sarcoid, including orbital sarcoid. And there may be evolution of the disease. Manifest later. The next condition we are going to be talking about is orbital vasculitis, GPA, granulomatosis with polyangiitis, which used to be called Wegener's. This patient, let us take her example. You can see the left eye is proptosed. There's a mass in the left orbit with bone erosion. And when we did a biopsy, it shows vasculitis, perivascular inflammation. Initially, ANCA was positive. So when we test for ANCA for GPA, it should be by the ELISA method. Initially, the ANCA turned negative on treatment and she was treated with cyclophosphamide. After 10 years, she had an orbital recurrence with once again ANCA positive, and this time she presented also with hematuria. Let's take this other lady. She initially presented with acute inflammation, which was treated, and she recovered. But after 8 months, she again presented with scleritis. So in GPA, we are looking at certain systemic which would include nasal and PNS involvement, which might include, nose bleeding, crusting, nasal discharge. There may be renal involvement with hematuria and lungs with dyspnea and fibrosis. Localized effect on the eyes would be frequently seen in the lacrimal gland, which might lead to dry eye. 10% of the patients will have scleritis or uveitis. And once again, this is one condition where scleritis is associated with orbital inflammation. There may be enophthalmos, there may be bone erosion, and there may be early visual loss due to orbital vascular infarction. Sclerosing inflammation has always been a kind of challenge for clinicians. It's a primary chronic immune-mediated fibrosis, but there's desmoplasia and very few cells. It's paucicellular. The commonest location is in the lacrimal gland. However, it spreads and it kind of obliterates the orbital structures. There may be intracranial involvement and there may be bone involvement. And about 30% will actually not respond to either steroid or radiation. Let's take an example of this gentleman. He presented initially at 2012 with the medial rectus and surrounding tissues involved. And he was put on high-dose steroid as well as immunosuppressant. But over the years, the condition kept increasing. The biopsy confirmed that there's a sclerosing inflammation, but in spite of the treatment, it kept increasing and almost filled the orbit. And finally, because of the compression, he lost his vision. This is another gentleman where he presented like a typical myositis, but he wasn't responding at all, to the steroid and immunosuppressants that were added. So when I biopsied the muscle, it turned out to be a few islands of muscle fibers, but mostly fibrous inflammation, sclerosing inflammation. And we'll talk about muscle biopsy later, whether we should be doing it or we shouldn't be doing it. We come to the new kid on the block, the IgG4 related disease. We started hearing about these, say around 2007, 8 or so on in the Oculoplasty conferences. And I was wondering at that time, why are we so interested in it? And as time went by, I started seeing patients of different manifestations. You see this lady, she has been suffering for 7 years. Every time with the steroid, it comes down and it increased again. So like when she came to me, she was in this condition. She has pain, she has dry eye. Of course, the lacrimal gland is involved. There is limitation of ocular movement because the muscles are enlarged. Next, we come to this gentleman. This is again his second episode. In the second episode, he has myositis and compressive optic neuropathy with blurring of vision, both eyes. And the third gentleman, once again, is the second episode, came to me after being treated with steroids elsewhere. He has dacryoadenitis and he has surrounding scleritis, and he has pain and dry eye. So when we do a repeat biopsy or review the histopathology slides, and we do immunohistochemistry for IgG4, in the histopathology, there's typically lymphoplasmacytic infiltrate with storiform fibrosis. And IgG4 positive plasma cells, in this particular, the third patient, were more than 50 per high power field. The treatment would be combination of steroid as well as immunosuppressant. The lady now, after she came to me, she's been stable for about 2 years and maintained on methotrexate. So we see that the gender distribution is equal. It may be any location in the orbit. You saw the different variations. However, bilateral disease and dacryoadenitis is more indicative of IgG4-related disease. This condition may be sclerosing or non-sclerosing. Remember, there was fibrosis and sclerosis along with lymphoplasmacytic infiltrate. The proportion may vary. Initially, they'll always respond to steroid, but then if it is only steroid, there's a very high chance of recurrence. Once the awareness of IgG4-related orbital disease grew, a lot of doctors reviewed their old lists, old cohorts of idiopathic orbital disease, and reclassified 25% to 40% as IgG-related disease. Radiology, however, cannot differentiate between non-steroidal orbital disease, lymphoma, and IgG4-related disease, except for infraorbital nerve involvement. If you will recall, the gentleman in the center, when we were looking at the different manifestations, had this infraorbital nerve thickening. So there are certain criteria to diagnose IgG4-related disease. We are talking about diffuse or localized mass. We are talking about elevated serum IgG4 levels. And we are talking about a histopathologic manifestation, which shows lymphocyte and plasmacyte infiltrate and IgG4 plasma cells. So IgG4 to IgG cells the ratio should be more than or equal to 40%. And for the general IgG4 disease, systemic IgG4 disease, we are talking about more than 10 IgG4 positive cells per high power field. However, when we look at the criteria for ophthalmic manifestation, the imaging would need to show lacrimal gland or trigeminal nerve or extraocular muscle, as well as masses. Blood tests should show elevated serum IgG4 more than 135. Histopathology should show lymphocyte and plasmacyte infiltrate and sometimes fibrosis, and IgG4 IgG ratio more than 40%, or more than 50 IgG4 plasma cells per high power field. So you can see the criteria are slightly different between the systemic and the ophthalmic disease. So now, if all three criteria are present, it's a definite IgG4 disease. However, if it is only histopathology present as well as the clinical mass present, it is a probable IgG4 disease. If it is the orbital mass and only serum IgG4 positive, then it is a possible IgG4 disease. So how do we treat it? There's a good early response to steroid, but there will be 30 to 40% relapse. There's a good response to methotrexate. And rituximab is actually very good in IgG4 disease. It depletes the B cell population, so which would be, the parent line for the plasma cells, and so reduces the chance of relapse. It is effective for 14 to 17 months. But also worrisome about IgG4 related disease are the reports that there can be combination of IgG4 related disease and extramarginal zone lymphomas. The next condition we come to is Sjogren's syndrome. Typically, we know of this as a dry eye disease. However, the orbital surgeon becomes concerned because there's an enlargement of the lacrimal gland. There is a dry eye, there's also a dry mouth, and you may be able to spot parotid enlargement or submandibular enlargement. There can be systemic conditions also, such as fatigue, myalgia, fever. Now, we don't really need to treat these patients with steroids. It's symptomatic treatment for dry eye and treatment for dry mouth. Only if there's a systemic symptom, fever, fatigue, and so on, disease-modifying agents such as hydroxychloroquine are used. So now that we've talked about the common specific orbital inflammations, now we come to the non-specific orbital inflammations. As we said that, the pool of the non-specific orbital inflammation is shrinking. That when we investigate more and more, we actually find that a lot of the so-called idiopathic or orbital inflammations are not idiopathic at all. We can put a name to it. So in 2017, certain criteria were set forward for diagnosis of non-specific orbital inflammation. So there should be pain with an acute or subacute onset. The bones are not involved. There's no systemic disease. There's no sinus disease. So if you will slowly think about all the specific entities we have talked about, we are kind of ruling them out one by one. Bones are not involved. That means if we see a bony erosion, as we saw in the GPA, even on the scan, we know this is possibly not an idiopathic inflammation. If there's no systemic disease, no involvement of the chest, no involvement of the skin, this is possibly only if there's no other systemic involvement will we think towards idiopathic inflammation. Sinus disease, again, would be common in GPA. Now, idiopathic orbital inflammation is a diagnosis of exclusion. For non-myocytic disease, we are talking about imaging, blood tests, and incisional biopsy. And for myocytic disease, necessarily it's not very feasible to go around biopsying the recti. So the criteria include imaging, blood tests, and response to steroids. So far as imaging is concerned, CT scan and MRI are equally useful. It's usually going to be an enhancing condition. Either it's going to be an enlargement of the muscle or the lacrimal gland. There may be some ragged edges, or there will be a diffuse inflammation or a mass lesion in the orbit itself. Myositis at first go is pretty responsive to steroids, so it makes sense to take that as a diagnostic criteria. Now, when we talk about blood tests, interestingly enough, we are talking all about negative blood tests. Okay, so the first set we are talking about is CBC, ESR, CRP. So if blood counts are elevated, we are probably going towards an infective condition, not one of the idiopathic orbital inflammation. We talked about ANCA. Particularly significant is the ANCA with ELISA and ACE, IgG4. If any of these are positive, automatically your idiopathic orbital inflammation is a no-starter. If there's muscle involvement, if the recti are involved, then we do have to do thyroid function tests. I know we talked about the myositis saying that the tendon would be involved, whereas in the thyroid eye disease, the tendon will not be involved. However, it is also known in exceptional cases, in certain thyroid eye disease, the muscle tendon is involved. So if you see an inflammatory condition with muscle involvement, thyroid function tests are necessary. If the lacrimal gland is involved, we need to check for Sjogren's syndrome. So anti-Rho or SSA and anti-La SSB, these need to be done. Sjogren's syndrome might be primary or secondary, associated with SLE or rheumatoid arthritis and so on. So rheumatoid factor and ANA need to be checked. The next point we come to in an idiopathic orbital inflammation is the pathology. We need to do a good incisional biopsy. And in idiopathic orbital inflammation, we are probably going to get a lymphoplasmacytic infiltrate, which may be a mixed infiltrate with some neutrophil, eosinophil, a few histiocytes. So there's no granulomatous infiltrate, no vasculitis, and no necrosis. Now, necrosis in the granulomatous inflammation would have been, we'd be talking about TB. In this kind of infiltrate, if immunohistochemistry is done, IgG4 cells would be less than 30 per high power field, and IgG4 to IgG ratio would be less than 40%. So with this kind of background, then we start talking about how we are going to investigate a patient typically with orbital inflammation, where we are suspecting an orbital inflammation. Supposing a patient comes in with swelling, pain, proptosis, limitation of movement, all the things that we talked about. In a typical eye setup, eye hospital setup, what are the things we can do the quickest immediately after they come in? Well, if we do an orbital B scan, that rules out the localization of, a cystic lesion, which could be an orbital cysticercosis, it could be an inflamed dermoid. The oily material leaking from a dermoid can also set up a pretty typical orbital inflammation-like picture. So an orbital B scan is very easy to do. If we do blood counts, if we see high neutrophils as well as high ESR and CRP, we are probably going towards an orbital cellulitis rather than one of the non-infective orbital inflammatory disease. An orbital CT scan is important. Like we found out that MRI and CT scan don't make much of a difference. And so a CT scan is absolutely acceptable. In fact, it would give us the idea about the bone erosion. Now, the next set that I've written, blood sugar, chest X-ray, and Mantoux test. In our context of patients, this is useful. Now, this may not always directly lead to diagnosis, but the highest chance is that we are going to start these patients on steroids. So we do need to get the blood sugar. We do need to get a chest X-ray, even if we are not suspecting anything. If the patient cannot afford a CCT thorax, fine and good. At least a chest X-ray PA view is necessary. And that is because we never know who among our patients is a potential COX patient. And we need to look for systemic malaise. Systemic malaise is very typical for orbital cellulitis. So in this first set of tests, we have actually ruled out orbital cellulitis, we've ruled out cysticercosis, we've ruled out inflamed dermoids. So once we've ruled these out, the way to approach it is, if there's a myositis, of course, we are going to start with steroids. And if it is a very typical first episode of, say, dacryoadenitis, it is worthwhile starting with oral steroids, a challenge. However, if it is subacute, or if there's a mass lesion presentation, we absolutely need to do an incisional biopsy. And the other tests can be guided by what comes out of the biopsy. If by chance the patient who's come to us has been on steroids, we need to wash out the steroids for at least 2 weeks to get an accurate histopathological picture. If there is a vasculitic pattern, we will be suspecting a GPA. And so therefore, we are going to request an anchor as well as imaging for the PNS, the lungs, and the renal condition, renal function tests should be checked. If it is a granulomatous inflammation, granulomatous picture, stains for acid-fast bacilli. PAS and GMS are done to rule out fungal infection. As I mentioned, we do a PCR for MTB, image of the thorax, and ACE. If there's a sclerosing inflammation, we would also look for specific IgG for specific pattern. Now, this chart, I finally, now probably this is available in textbooks, but I'd actually put it together from different places because I found this useful as a ready reckoner for myself. So which tests do we order when? If you're talking about SSA, SSB, that's anti-Rho and anti-La. If there's dry mouth and enlarged lacrimal glands, and we're suspecting Sjogren's, that is when we ask for these. And it is positive in 70% of the patients. Same for rheumatoid factor. If there's dry mouth, enlarged lacrimal gland, dry eyes, we would also ask for the rheumatoid factor. dsDNA would possibly be positive in SLE. So we are talking about fever, we are talking about the butterfly rash, we are talking about lung involvement. So otherwise, dsDNA doesn't really need to be checked for a typical orbital inflammatory disease. It's not very common. ANCA does need to be checked whenever there's a vasculitic pattern, and particularly if there's an associated PNS disease. So this has a high sensitivity as well as specificity, and it also monitors disease activity. When we discuss that particular patient who had an ANCA positive and then it became negative, and 10 years later, when the disease reactivated, it became positive again. So it can be used to monitor the disease activity. ACE is particularly specific for sarcoidosis. Now, for practitioners, here's a word of warning. Make sure that your lab, unless it's a lab you regularly use, make sure they understand what you've asked for. Because unfortunately, some of the labs will give you AEC, absolute eosinophil count. So make sure what the communication is good. So we ask for ACE after a biopsy shows a granulomatous inflammation, with or without a chest imaging positive. And it may be positive in 50 to 80% of patients. Now we come down to the medical management of the patient. Usually, I would want to give a full dose steroid. There's no point giving a low dose steroid right at the beginning. If it doesn't respond, you're not sure whether it is because you've given too low a dose or whether because it's something else and it's non-responsive to steroids. So give the full dose with whatever precautions are necessary. Check the blood sugar, check the liver function test, make sure you give them calcium supplementation. If necessary, if it's a known diabetic patient, take the help of your physician to monitor. If the sugar goes out of control, give them insulin, but give them the full dose of steroids. And once it responds, do not taper it 3 days at a time. That's too fast a taper. Do a slow taper, about maybe even 2 weeks at a time. Step it down very slowly. If you worked with rheumatologists, you'll see they go at it very, very slow. And towards the end, they bring it down to 5 milligram or 2.5 milligram and really continue for 3 or 4 weeks, even on that. Now, in spite of all this precaution, we will still have patients who are intolerant to steroids. So how do we get around it? Well, we could be doing pulse IV methylprednisolone. We can actually use local injection of triamcinolone as a supplement, and we can take the help of our rheumatology colleagues to put the patient on immunosuppressants. Among the immunosuppressants that they commonly use possibly methotrexate is the safest. But a stronger disease, such as GPA, which is potentially a life-threatening condition, will possibly need cyclophosphamide. Rituximab and many of the monoclonal antibodies are now actually coming into play, and there's quite an array of it. Rituximab is already pretty much in use in ophthalmology context, and particularly in the context of IgG4 disease. Other immunomodulating diseases, agents that have come in include the mycophenolate mofetil. In addition, if you get quite desperate, this is not the first line of treatment, where you see that the immunosuppressants are not enough, the patient doesn't tolerate steroid, even a low-dose orbital radiation is a possible treatment for orbital inflammatory disease, but definitely not the first line of treatment. So this is an example of a lady who couldn't tolerate steroids at all. And this was her second episode of inflammation. And so we treated her only with intralesional triamcinolone. And she responded very, very well. So to summarize, we talked about what orbital inflammation entails: pain, swelling, redness, and diminished function. There are localized patterns. However, localized patterns are only a guide to what we might expect clinically on clinical examination. We need to go beyond that and look at specific orbital inflammations, their histopathology patterns, the associated systemic and ocular manifestations. The non-specific or idiopathic orbital inflammation is to be diagnosed only after excluding the specific orbital inflammations. And hence the name of the lecture, that specific and non-specific inflammation. And we talked about the approach to investigation and management. Thank you.
Thank you so very much, ma'am, for that lucid presentation and for covering the orbital inflammation, both specific and non-specific, in such great detail. We do have a lot of questions from the social media portals, ma'am. If you may permit, then we shall go ahead with those questions.
Please go ahead.
Yes, ma'am. The first is, clinically, how do we differentiate thyroid eye disease versus myositis in terms of its presentation, and what is the preferred imaging of choice?
Okay. Thyroid eye disease. If you look at the criteria of diagnosing thyroid eye disease, there are two sets of criteria. Okay, so the first set talks about thyroid dysfunction with any one of the following: proptosis or muscle involvement or imaging, so on. And the other set of criteria talk about eyelid manifestations. So here, since in thyroid eye disease, 90% of them will have some kind of an eyelid manifestation. That is a very, very critical point. Some kind of a lid retraction, or in the early stages, a lateral flare. So that with thyroid dysfunction or proptosis or radiology or the muscle involvement. Whereas in orbital myositis, we are talking isolated muscles. Yes, it is true enough that, so to say, thyroid eye disease will be it'll more commonly start with inferior or medial recti, whereas myositis could be any of the muscles, but that is not enough to make the distinction. Next comes to the point of, are we talking about MRI or CT scan?
Yeah.
If it is contrast enhanced, it doesn't make too much of a difference. We are looking at the surrounding inflammation. We are looking at whether the tendon is involved or not. And we are looking at the typical shape of the muscle. In thyroid eye disease, the typical shape of the muscle is very specific. People call it that Coca-Cola sign or whatever. Coca-Cola, yeah, that's a Coca-Cola sign. Whereas if you noticed, all the images of orbital myositis I shared, the muscles were kind of randomly thickened, generalized thickening. I hope that answers the question.
Yes, ma'am. Ma'am, one question from my end on that to add to it. If you were to give two radiographs, like say CT or MRI, contrast enhanced, is there a preferential involvement of the recti muscles in TED versus myositis?
Preferential involvement of what? Like
Of
which
recti
muscle?
muscles. Yeah, of recti muscles in thyroid eye disease versus myositis,
Yeah.
say multifocal myositis.
Typically, what is described is in thyroid eye disease, it's the inferior and the medial recti which are preferentially involved, which is where, a lot of patients in the initial stages will come and complain that they're having difficulty reading,
Hmm. Okay.
even
Or the
before other
lack of
things happen. They
convergence
say,
of
yeah, correct. The
okay.
convergence and downward gaze, they get affected.
Okay. Ma'am, the second question is factors that point towards possibility of a recurrence in a case of a multifocal myositis.
Okay, what might lead to recurrence? Well,
Yes.
one of the possible you have me a little stumped there.
Okay.
Yeah? Because multifocal myositis is known to recur in about 25 to 30% cases, no matter what.
Okay.
But probably an incomplete or an inadequate treatment, maybe. I'm not.
Is that the question? I think they're talking about clinical appearance or something.
Oh, okay. I'm not sure.
Yeah.
Is that
what they meant?
you mean? The clinical features which it can indicate?
Yeah, I think that is what the question meant.
Okay.
Maybe, ma'am. We can then move on to the third question for tonight is when do we consider intravenous methylprednisolone and is there a protocol that we follow while we give IVNP?
Okay, so now here I know Dr. Honavar has done quite a bit of work on use of intravenous methylprednisolone for orbital inflammatory disease. This is actually, it's not a generalized, standardized protocol though. For a lot of the people, the intravenous methylprednisolone comes in only when we see a very critical stage of orbital inflammation. The optic nerve is getting compressed.
Mm-hmm.
It's not responding to full dose of oral steroids. The patient is not tolerating full dose of oral steroids. I would switch to a pulse methylprednisolone only then.
Okay.
But one of you who's been working with Dr. Honavar, you might want to describe his regimen.
Yes, ma'am. It is like in orbital inflammation, let us say TED or myositis.
Okay, no. TED has a very specific defined criteria.
Correct.
A very defined protocol. So we are not talking about TED here.
Okay. So if we were to restrict ourselves to the discussion of say myositis and then we plan on starting intravenous methylprednisolone, then it is always a loading dose for the first pulse given on 3 consecutive days and the dose being 500 milligrams intravenous. Then it's a 3-weekly pulse for 6 such pulses and each pulse when the patient comes to us is thoroughly examined for any functional issues and the various set of our let us say Hertel's exophthalmometry or all the other diplopia and ocular motility restriction.
The response is checked at each.
Responses checked at each pulse and then probably at around the third or the fourth pulse, then we plan on adding either oral steroids to it or oral immunomodulators to it, which can be either azathioprine or mycophenolate method.
Okay. So here, let's look at a variation of this. There are points, plus and minus points of using IV methylprednisolone as well as oral steroids. IV methylprednisolone has the benefit of not suppressing the hypothalamic pituitary axis. That's a huge advantage. And so therefore, the systemic side effects are going to be less. However, the downside is it needs, so to say, hospitalization for a few hours. It needs intense monitoring in those phases. So that is one thing. On the other hand, oral steroids can be given, administered with the patient ambulatory at home. Even the checks that need to be done, the blood sugar levels and so on, the patient can even do at a remote location and send it across to you. However, oral steroids for too long will actually suppress the corticosteroid axis.
Yeah.
Either ways, I would say that if it is a recurrent inflammation, we do need to add on something extra. The first line, what we did was not enough. So if it's a recurrent orbital inflammation, we do have to give some kind of immunosuppressant. So, of course, at your place, you're familiar and you're used to using azathioprine or mycophenolate. I would use mycophenolate for thyroid eye disease. That's the current Yogogo recommendation. And the rheumatologists I've been working with over the last many years, they have always been of the opinion that methotrexate is probably the safest immunosuppressant to use.
Okay.
And so then I would be inclined to be using methotrexate.
Okay. Point well taken. Yeah.
I had a couple of questions, especially regarding IgG4 disease.
Sure.
There are specific criteria, but more often than not, it doesn't really meet those criteria when we do a biopsy and, based on the histopathology or the ratios, they either are in the borderline or they don't, fulfill all the criteria. So in those cases, do you advise systemic evaluation as well in terms of abdominal CT or chest CT and things like that?
The thoracic imaging is definitely part of the workup of all the specific orbital inflammations anyway. So that is part of it.
Right.
When I treat IgG4 disease, it is always in conjunction with the rheumatologist. So say in the abdomen, what are we looking for? We are looking for retroperitoneal fibrosis. Okay. So what might it manifest as? As something in the biliary system, something in the ureters. So we are looking at the liver function tests, we are looking at the kidney function test, we are looking at the urine. This much definitely we are doing. Your point is very valid that there are often, it is a kind of borderline case. Your point there is absolutely correct.
Maybe now move on to the next question, ma'am. In a case of orbital inflammation with a mass in the lacrimal gland or a lacrimal gland mass, involvement of both palpebral and orbital lobe noted, what would be your preferred approach in a biopsy of such a case?
Okay. So, and is it bilateral lacrimal gland or unilateral lacrimal?
Bilateral, yeah.
Ouch. Okay.
Okay.
And I am presuming that the imaging does not show molding around the globe.
Yes, yes. Even I
Okay.
presume so. Yeah.
So I'm presuming that, and so therefore lymphoproliferative diseases is not immediately evident. Okay. So I would want to actually go subbrow and take a biopsy from the orbital part of the
Black hole.
mass.
Okay.
And I would, even though there are reports of having different pathologies in two different lacrimal glands, I would say the probability of that happening is pretty minuscule. The reports that have come of lymphoma in a lacrimal gland have always come in an IgG4 disease. Right? So that might be kept in mind. If in future I come across, okay, one side shows IgG4 disease, I may want to biopsy the other side. But more commonly, I would probably biopsy the side which is a little larger if there's an asymmetry, and I would biopsy through a subbrow incision and only the orbital part. I would not touch the palpebral part. And
also,
that because, of
Okay.
course, it hardly needs elucidating to you people, but in case somebody would be wanting to know, is because all the lacrimal gland ducts are passing through the palpebral lobe. You want to leave them intact. If you damage them, in effect, you're stopping all functioning of that gland. And even though these patients often present with dry eyes when there's dacroadenitis, as you treat them, if you actually do a Schirmer's and follow it up, you'll see that the tear secretion improves, it recovers.
Also, ma'am, in the biopsy of the orbital part of the lesion of such a lesion, do you prefer a multi-level incision biopsy?
Okay, I would probably, once again, that I know has been the focus of Dr. Hunaver's work in the last few years. I would actually want to do an adequate biopsy going from the surface to quite a bit of depth to up to the center.
Okay.
I don't do it really formally, superficial, medium, deep, not like that.
Okay.
But I have an ocular pathologist who I've been working with on and off, Dr. Shruti. Quite frequently, I've been working with her. If in doubt, I do not hesitate to send out two specimens at the same time.
Okay.
One to her and another to one of the oncology centers.
Okay. The next question, ma'am, how do we differentiate a patient presenting with a clinical picture of proptosis, a red eye with chemosis, diplopia, and ocular motility restriction with MRI or a CT showing enlarged muscle bellies in a case of multifocal NSOID versus a low-flow dural cavernous fistula?
Okay. So, okay. Low-flow dural cavernous fistula. So we are presuming that obviously the quote-unquote typical signs of pulsatile proptosis, bruit, all of that is not there.
Not there. Yeah.
Have we looked at the cavernous sinus? Have we looked at the superior ophthalmic vein? So these are the two critical signs that we have to look at: the superior ophthalmic vein and the cavernous sinus. Superior ophthalmic vein will, of course, be enhancing with the contrast, and it will be widened on the side that is affected. And it doesn't happen in any of the myositis. And the cavernous sinus should normally be having concave outlines. The two sides should be having concave outlines. If they become convex, it indicates that the blood flow is more. And another point to remember is that these two signs are visible at different levels on the scans. When you go down the axial scans, these two signs are not at the same level. They're at different levels. The next thing is clinically, the congestion we are talking about. If we are talking about a vascular cause, especially a low flow dural fistula, it's an episcleral venous congestion. It's not a generalized congestion. You can actually see the episcleral veins enlarged. If I see episcleral congestion, I would routinely also check for intraocular pressure difference between the two eyes. I would also routinely do a gonioscopy.
For any blood in the
There may be blood in the Schlemm's canal.
Okay. Yes. The next question is presence of intralesional calcification in a lacrimal gland mass. How do we interpret and proceed with such a finding on a MRI on a CT?
Okay. Sarcoidosis or long-standing necrosis, long-standing inflammation can lead to calcification, right? So that probably is not so specific. I'm trying to think of what are the specific causes of calcification within a lacrimal gland mass. Is there a particular, you might ask the person, is there a particular context of a patient they're talking about?
This was on one of the social media portals that we have got this question from. Possibly they can write an email to you and then pinpoint as to what they actually wanted.
This sounds like there's a very specific context to it.
Yeah. The next question is, what are the causes of multi-cavitary involvement of orbital pathology? Involvement of probably paranasal sinuses, the intraorbital part, the orbital apex, and the orbital fissures.
Okay. So the ones that spread around like that, if you're talking inflammatory lesions, the first thing we need to be very sure of is that it should not be GPA, Wegener's, because that is notorious for going into the paranasal sinuses and the nasal cavity. And the other one that immediately comes to mind, which travels through the fissures, it may go intracranially, it may go into the sinuses, is what we already mentioned, sclerosing variant of orbital inflammatory disease. Now, of course, both of these are very difficult to treat.
Yeah. Ma'am, in refractory cases of orbital inflammation, or like say sclerosing form of NSOID or IgG4 related disease, after having a full course of intravenous methylprednisolone or oral immunomodulation, and then we are on the verge of probably starting rituximab, and then we have realized that after 2B, like second pulse of rituximab, we are still failed or like it has responded to a suboptimally. What is the next step ahead?
Okay. How sclerosed is it and how active is the disease? Okay. The last shot we can have at a disease which is not responding may be a low dose orbital radiation. The same kind of radiation you'd give for a thyroid eye disease. However, it may also be the sclerosing component is so high, the fibrotic component is so high that it's not going to regress. It's no longer active, but it's not going to regress either.
Ma'am, in cases which are like we request for a low dose orbital radiation, what is the protocol which you routinely follow? Like, do you add a form of neuroprotection to it, or just prevent exposure keratopathy. Is there any protocol that you follow with your patients?
It's the same kind. It's given at a much lower dose than the standard oncologic doses, right? Where in oncology, we are talking 40, 45 gray plus, sometimes 50 gray. Here, we are only talking about 20 gray.
Okay.
And nowadays, they give such specific targeted therapy. I don't really ask for anything extra.
Extra. Okay. And how frequently do you follow up these patients of, say, multifocal myositis or active TD or IgG4 related disease in your clinic? Like, how frequently is your follow protocol? Those are on active treatment.
Okay. For active treatment for, say, IgG4 related disease or GPA or myositis, I am going to check them every 3 to 4 weeks till they are weaned off the steroids. After that, about every 2 months or so, till they're weaned off the immunosuppressants as well, which might be, 18 months or 2 years or something.
Okay. And for those subset of patients who are receiving immunosuppression in any form,
Yeah.
how frequently do you monitor their hemograms?
Okay. So this is every 2 months or so. When they're just starting off, building up to the proper dose, it's monthly.
Okay.
And after that, it's every 2 months.
Okay. Ma'am, and during the course of the lecture, one of the points which you very well mentioned was of steroid washout. So in which subset of patients are we not waiting for a steroid washout before we biopsy them?
Would you at all do such a biopsy without waiting for a steroid washout?
Hmm.
Because, see, when we are washing out steroids, you taper it down quickly and then give a 2-week gap, right?
Yeah.
So we are
Yeah.
talking 3 or 4 weeks.
Correct. Yeah.
It might be a patient who's not responded to steroids at all.
Okay.
If a patient who has typically not responded at all, then it's unlikely that the steroids have had any effect on the histopathology inside.
Yeah. Likely. Yeah.
If a patient comes to you and has been on oral steroids, but currently is on a very low dose, say 20 milligram for a while,
Yeah.
do you still give that washout period? Or can you just, you can see that it's not responding?
I would still probably want to give a washout period.
Mm-hmm. Okay.
Because what I'm the most worried about is, am I missing a lymphoproliferative disease?
Right.
Right.
Yeah.
And see, unless the patient is in severe pain and orbital inflammatory disease, it's okay.
Yeah.
They're worried about the swelling. But unless they're in severe pain or unless there's compressive optic neuropathy, it's okay.
Yeah.
Yeah. I think that is all we have. A bag of questions for you. Thank you for so patiently answering them all.
Yeah.
Dr. Mritika, any concluding remarks?
No, I think she cleared out most of the points because this is a little ambiguous overall, especially for people who are not seeing this that often, the logical approach to it. And I think ma'am covered that really well. So thank you so much, ma'am.
Thank you. It's been a pleasure being with you people again.
Yeah, likewise, ma'am. Before we conclude today, I have a small announcement to make. We meet next on the 15th of December, this Friday. The topic being thyroid eye disease, diagnosis, the clinical radiological evaluation and grading by Dr. Akshara. See you all there. Good night, ma'am.
Good night.
Thank you and
Thank
good night.
you.